I'm honoured to introduce Dr. Fionnuala Áinle, who is a consultant haematologist in Dublin. I'm so sorry, Fionnuala, I cannot say the name of that hospital.
The Mother Hospital and the Rotunda Hospital is just fine. Thanks, Sylvia.
It sounds so much better when you say it anyway. So Fionnuala is a clinical professor and her main work focuses on patients affected with VTE, but she's also got a very strong interest in women's issues, in thrombosis and hemostasis. She acts as the director of the Irish Network for VTE Research, co-directs Sphere Research Group, works very closely with the Irish patient organisation Thrombosis Ireland, and is a member of the World Thrombosis Day International Steering Committee, serving as a council member. She's actively involved in international VTE clinical trials and training programmes and serves on the editorial board of several journals, including the Journal of Thrombosis and Hemostasis. So a very, very busy lady, and we are absolutely honoured to have her here this morning. So I'll hand over to Fionnuala, who's going to do her talk about VTE in pregnancy. There is a chat function. You can put questions throughout the talk. We can either answer them during the session or we can put them to Fionnuala at the end. Over to you.
Thank you, Sylvia, for the beautiful introduction and for the honour of being here today. I would like to apologise to all participants for joining on my iPhone, and for some of you who may have seen the news this morning, the reason for that is that there has been a terrible ransomware attack on some of our health IT systems in Ireland. So Joe is very kindly going to show my slides, which is fantastic. Thank you in advance, Joe, and to advance the slides as required. But just to apologise for the mode of joining, and just bear with me. If there are questions that I am not addressing at the end, because I can't adequately see the chat function, please shout, please let me know. I'm really excited to take all of your questions and looking forward to a great discussion afterwards. So without further ado, I might ask Joe, if you don't mind sharing the slides there. Thank you. Perfect. So look, my disclosures are myriad in that I hold research grants from the Irish Health Research Board and Science Foundation Ireland, which has made it absolutely possible to be involved in the kind of research that we're doing on behalf of our patients. And I hold investigator initiated grants from Leave Pharma, Telia and Bayer. So pulmonary embolism and VTE is a leading cause of maternal death, a devastating event with wide-reaching consequences for a woman's family, friends and society. And of course, for women who do survive, pulmonary embolism can have long-term consequences, including chronic thromboembolic disease and at worst, chronic thromboembolic pulmonary hypertension. And that's important as a background because it shows us why excellent pathways for diagnosing and treating pulmonary embolism during pregnancy are so important. Awareness is crucial, and we need to be aware, thanks Joe for that slide, and we need to be aware of a woman's risk of VTE when she becomes pregnant and her lifetime risk, and indeed her risk outside pregnancy. I usually at this point invite participants to share any stories that they might have or any experiences, but just given the virtual platform, we might leave that sort of discussion and sharing until the end. So I'll begin with a story. A 31-year-old woman is 6 weeks pregnant with her first baby. And she tells her doctor that she developed a pulmonary embolism 3 years ago while she was taking the oral contraceptive pill. And indeed, this was the estrogen-containing oral contraceptive pill. So we'll think about that, and we'll come back to that question later on, and how we handle prevention of venous thromboembolism in pregnancy in various different scenarios. So next slide, please. Thank you, Jen. Great. So as you all probably know, the baseline risk of venous thromboembolism increases when a woman is pregnant, and particularly after childbirth, such that the greatest risk is after the baby is born. And this may come as a surprise to some women, but it's crucial because, as you will hear later, planning and delivering VTE risk assessment in this very, very busy, high throughput time can be a real challenge. But this is why it's important to address. And of course, this is incredibly important to know because it allows us to identify women who are high risk, and particularly in the postpartum period. And this is important in order to discuss with these women in a shared manner ways that we can reduce their risk. Next slide, please. Including the consideration of thromboprophylaxis for women who reach a certain risk threshold. The majority will not need it, but for those who do, it is crucially important. And in fact, VTE risk assessment can save lives. Next slide, please. Because of course, as we know, venous thromboembolism tragically remains a leading cause of maternal mortality and can have many, many long-term consequences. Next slide, please. I noted earlier on that while the risk increases during pregnancy, the highest risk is after baby is born, as elegantly demonstrated by Dr. Sultan and colleagues in this beautiful paper using information from the UK Primary Care Clinical Practice Research Data Link and Secondary Care Hospital Episode Statistics between 1997 and 2010. Next slide, please. And the impact cannot be overstated. A maternal death due to pulmonary embolism is a truly devastating event with wide-reaching consequences for her family, friends, and society. And just to note that all of the beautiful illustrations that I showed during this talk are by our student, Ms. Renata Donchu, and they represent a story, because every case is a story. And in this case, the 35 women whose deaths due to pulmonary embolism were reported in the most recent UK and Ireland triennial report into maternal deaths. Next slide, please. Next slide, Jill. Thanks a million. So we've talked about a woman's baseline risk, which for a healthy woman without additional risk factors is very low outside pregnancy. So of the order of, 1 in 10,000 to 1 in 5,000. However, for all women, the risk increases during pregnancy, still not to a level that warrants thromboprophylaxis with pharmacological methods for the majority of women. However, we need to be extremely aware of additional maternal pregnancy and delivery characteristics, because these characteristics can increase this elevated risk during pregnancy and postpartum further. Variable odds ratios have been reported in the literature, and there are many risk factors. And therefore, from an operational perspective, it is absolutely crucial that VTE risk assessment is carried out in early pregnancy, at delivery, and if risk factors change. So let that sink in. And it's a lot of work, but let's anchor back to the reason that we are doing this: to save lives, prevent morbidity, and have healthy women and babies leaving our maternity hospitals. Next slide, please. What is now very certain is that VTE risk factors are very common in pregnancy and postpartum. And we conducted a prospective study recently, including 21,000 women in the Rotunda Hospital. This is a maternity hospital, a standalone hospital where I'm honoured to provide services. And next slide, please, Joe. Thanks a million. With a huge shout out to the phenomenal multidisciplinary team who made this study and indeed this initiative, patient safety initiative, a reality. We found that VTE risk factors are very common in pregnancy and postpartum, and that in fact 4 in 5 women had at least one VTE risk factor. If you could click, thank you, Jill. 1 in 3 were overweight and obese, and 1 in 3 had an age greater than 35. Next click, please. Thank you, Joe. More than 2 in 5 women had 2 or more VTE risk factors. So it's so crucial to do this risk assessment for every single woman who is pregnant who presents to your maternity hospital. Next click, please. Oh, thank you, Joe. Sorry. Yeah, 1/5 of women had no VTE risk factors prior to delivery, but developed them during delivery and the postpartum period. And that is a staggering, statistic that highlights the crucial importance of repeating a VTE risk assessment in the postpartum period, because if we don't, we will miss opportunities to prevent VTE in the postpartum period and to do better for our patients. Next slide. And to pick up these risk factors and to identify if a patient is at high risk, and I believe we don't have any patients with us today, but a key point is to involve our patients in this risk assessment. So it's really, really important that we do this. Otherwise, we can miss so many risk factors that do not arise early pregnancy and that are only visible to us if we specifically assess for them at the time of labour and delivery. Next slide, please. So the $6 million question is, can we reduce the risk of VTE in pregnancy and postpartum? Having done a risk assessment in all of our patients and having identified risk factors, how do we handle these? What data do we have? And unfortunately, guidelines at the moment are mainly based on expert opinion rather than high quality evidence. And this for me is a social justice issue. It's because women have been excluded from high quality clinical trials in the past, but that is changing. And we need to work together to make sure that it continues to change. So therefore, guidelines vary dramatically around the world. And the threshold at which thromboprophylaxis is recommended varies dramatically. And that can cause a huge amount of confusion and mixed messaging when our clinicians transition between different countries and different hospitals. And the other challenge is that we must remember the competing risks of pharmacological thromboprophylaxis, because on one hand, we want to prevent a potentially life-threatening pulmonary embolism, but on the other, risk factors of that intervention can include, next slide, bleeding, bruising, skin reactions, the pain, which can be really common. And in many countries, women pay out of pocket for this. So for example, in Ireland, the cost of low molecular weight heparin throughout the entire pregnancy is a staggering, between 1,300 and 1,500 euro. And I'm sure it's fairly similar in other jurisdictions where it's not covered. So, it's not a small thing to have to do this to self-administer low market heparin throughout pregnancy, or even for the postpartum period. Next question. Sorry, next slide. So the key thing is we need more data to answer these important questions. And the great news is that for some of the higher risk factors, high quality data are going to be available very, very soon. And the first example is the Highlevel study, led by Professor Saskia Middeldorp, who's taken over as chair of medicine in Radboud University in the Netherlands, but has led on this study for many, many years. Highlevel addresses a crucial question for women who are currently pregnant and have had a previous venous thromboembolism that is either unprovoked or provoked by minor or hormonal risk factors, but not by non-hormonal major risk factors. And at the moment, the optimal strategy for preventing thrombosis recurrence in these women is unknown. And in the Highlevel study, women have been randomized in a multi-center, multinational, academic randomized controlled trial to receive either prophylactic or intermediate intensity low molecular weight heparin, and are followed up to 3 months postpartum for the outcomes of recurrent VTE and bleeding, And the phenomenal news is that the Highlevel study completed recruitment at the end of October. And we look forward to high quality data addressing this really important question very, very soon. And we were deeply proud to participate in this study in the Rotunda Hospital in Dublin. And it was only made possible by the phenomenal input of our multidisciplinary colleagues, supported by the Health Research Board. Next slide, please. And also a very exciting study on the horizon that has been commenced in a pilot phase already in Calgary is the Partum trial. So the Partum trial addresses the optimal strategy for postpartum VTE prevention. And again, this is such a crucial question because to date, we really only have decent quality data for the situations of, perhaps you could argue, thrombophilia and previous VTE. However, there are, as you know, as I've shown you, many, many other VTE risk factors that can arise, and how to handle them remains a knowledge gap. So the Partum trial is led by Dr. Leslie Skeeth, an inspirational colleague from the University of Calgary in Canada. And she is leading in the first phase a pilot trial addressing the role of low-dose aspirin in women without absolute indications for low microcephaly in the postpartum period in order to prevent postpartum VTE. So again, fantastic to see a multinational academic, multi-center randomized trial addressing one of the most important questions and knowledge gaps that we face on a day-to-day basis. So honored to be involved, and huge congratulations to the entire team. Next slide, please. So in the Rotunda Hospital, as I explained earlier on, we asked ourselves many years ago whether it was possible to deliver risk assessment for venous thromboembolism to all pregnant women upon labour and delivery. I explained to you already why this is important. Up to 20% of women will only have these risk factors detectable for the first time in the peripartum period. So it's absolutely crucial that we find a way to risk assess all of our women, all of our patients at the time of labour and delivery. And it's obviously a really busy time. And I have continuous deep admiration for midwifery colleagues for making this a reality. And in the Rotunda, led by my pharmacy colleagues, Professor Brian Cleary and Dr. Fergal O'Shaughnessy, and by the entire multidisciplinary team, obstetricians, Dr. Donnelly, Dr. Cooley, and a variety of midwifery staff and other colleagues, anaesthetics, an electronic risk assessment system that is very, very user-friendly, developed with multidisciplinary stakeholder engagement, was implemented. And the great news is that with good multidisciplinary collaboration, as we show here, it is possible to risk assess nearly 100% of pregnant women who have just delivered. Next slide, please. So let's move on then for the last few minutes to the treatment of venous thromboembolism during pregnancy. So for women who have been diagnosed with a thrombotic event, next slide, please. Thank you. Low molecular weight heparin is the treatment of choice. And this is because oral agents cross the placenta and can cause fetal abnormalities and bleeding complications. But of course, low molecular heparin is not licensed during pregnancy. Nevertheless, it is recommended by all international guidelines as a treatment of choice. It's important to note that the data we have on low molecular heparin therapy during pregnancy is not based on randomized trials, but on case control and cohort studies. You know, I suppose some work still needs to be done to improve their efficacy and safety profile, particularly during the highest risk periods. And, you know, multidisciplinary collaboration is so important because recurrent events do happen during pregnancy, particularly during the first week. And for women who have been diagnosed with a VTE during pregnancy, involvement of an entire team of experienced colleagues is so crucial. Lumekrit heparin can be given as an injection under the skin, so subcutaneous injection, and compared to unfractionated heparin involves less frequent dosing, obviously, and fixed or weight-based dosing as a pragmatic option, and that is recommended by international guidelines. And the good news for all of our patients is that Lumekrit heparin is associated with a lower risk of complications than older forms of heparin. Next slide. Thanks, Jill. And I alluded to the efficacy and safety of Lumekrit heparin during pregnancy. And of course, we don't have randomized trial data, but again, you'll all be familiar perhaps with this fantastic systematic review and meta-analysis conducted in 2005 by Professor Greer and Professor Nelson Piercy. This was a huge study involving nearly 3,000 patients. And when we look at how many of those women had Lumekrit heparin for VTE treatment, there were 174. And of those patients, recurrent venous thromboembolism occurred in 1%, bleeding in 2%, allergic reactions in 1%. And usefully, in contrast to maybe older forms of heparin, including unfractionated heparin, heparin-induced thrombocytopenia and osteoporosis, in this case here is reported for treatment dosing in 0% of women. Next slide, please. And it is so crucial that we work together as a multidisciplinary team, because in the absence of high quality data, what we do have is very experienced colleagues who are all willing to work together to advocate for the pregnant woman and for her baby. And this is a photograph of all of my amazing colleagues in the Rotunda Hospital who collaborate on a daily basis to deliver this sort of care, and involves the collaboration of an obstetrician, a hematologist, an anaesthetist or intensivist, physicians when required, depending on other complications that a woman might have, and radiology colleagues. And in the hospital where I'm privileged to work with pregnant mothers, the Rotunda Hospital, we have a joint formal multidisciplinary team meeting with our general hospital colleagues on the Matters site. And we hold this meeting regularly, agree in real time on shared pathways that are shared with the patient and that are amended as the pregnancy goes on. And that reduces, that delivers messages in a fail-safe way that ensures high quality care and safety for our patients at the time of labour and delivery, so that the planning of delivering low molecular heparin around the time of labour and delivery can be planned such that it minimises the risk of recurrent thrombosis and minimises the risk of bleeding, so that we are not faced with that terrible rock in the hard face scenario. Next slide, please, Jo. Thank you. So my take-home messages are awareness, awareness, awareness. So the more the team is aware that VTE is a leading cause of direct maternal death and complications, the more committed they are to helping patients and to doing better. Risk assessment is crucial, and each hospital needs to find their own strategy to make that work, and particularly in the really high throughput, busy environment of the postpartum period. Shared decision making is always so important, and no more so than in pregnancy when we don't always have high quality data. And let's work together. Next slide, please. Click one. Thank you very much. And I just want to give a shout out and a thank you to the entire Rotunda Hospital and Mater Hospital multidisciplinary team who are photographed here. Next slide. To the team that developed the Thrombocalc initiative, and this is the tool I showed you, and that ensures that all of our patients are risk assessed in the peripartum period. Next slide, please. Huge admiration and respect to Professor Middledorf, the lead investigator of the multinational Highlevel study, and we were honoured to work with you, Professor Middledorf, and we look forward to those data later on. And next click, please. To my colleagues on the World Thrombosis Day Steering Committee, in particular, Professor Beverly Hunt and Professor Claire McClintock, who work tirelessly on a daily basis, and I've seen it in action. I cannot express highly enough my admiration for the work that they do. every single day to ensure the safety of our patients and to promote academic rigor in this area. And next slide, please. And finally, to Patricia Maguire, my co-director of the UCD Conway Sphere Research Group, and responsible for some of the translational research we talked about, and Miss Renata Donchu, last click, who did all of the beautiful illustrations that tell all of the stories. Thank you very much for your attention. And I'd love to take any questions that you might have now. Can you hear me, Sylvia?
Yeah, so there's a couple of questions coming through now. So the first one is from Sajida Kazi. Thank you very much. What's your view on the use of anti-10A monitoring for women on therapeutic low molecular weight heparin? And would you offer it to specific groups only?
That's a really great question and very, very topical one, and just goes back to you know, if we always anchor ourselves to high quality data, we can't go far wrong. So I had the honor of collaborating on the European Society of Cardiology guidelines for acute pulmonary embolism, and this is addressed within the guidelines. So we make reference to the fact that when we do a test, we have to anchor the data we get to clinical outcomes, and that's not something that is available to us when we measure anti-10A levels for low molecular heparin during pregnancy. We'll have seen, you know, data published on discrepant results, you know, variable results on a single sample in different NECWAS surveys, which just demonstrates the particular maybe limitations of the assay. But it's so important to note that we don't have a validated reference range or target that we should be aiming to achieve with a particular dose. And the other thing to bear in mind is that there are competing risks. So if we increase the dose of low molecular heparin to chase a number to achieve a particular target, that comes at the cost of increasing bleeding complications potentially, and is not evidence-based. So in general, we do not recommend anti-10A monitoring on low molecular heparin, and of course, in special circumstances, when you have the involvement of a very, very senior, highly experienced team, it is done, and this might include women with renal impairment, who are at extremes of body weight, who have who have mechanical heart valves, apologies, that Professor Gemma McClintock, and has some beautiful guidelines that are, I believe, being updated as we speak. So there are special circumstances where, you know, just with the caveat that we need to work within a very experienced team, where we sometimes do monitor, but in general, no.
Okay, next questions, Naomi. For the prevention of VTE and treatment of VTE, are you using booking in weight or actual weight?
Yeah, so for the prevention of VTE, we use the early pregnancy or booking weight, whichever is available. Pre-pregnancy weight, if we, you know, is useful if we have it, but unfortunately it's very rarely available in my experience. But that's a great question. We just need to be careful about dose increases, you know, during pregnancy, because of course, you know, the pharmacokinetic considerations, and we need to be making sure that we're delivering safe treatment.
Okay, next one's from Mauro Colasso. I'm so sorry if I've said your name wrong. He's thanking you for an excellent presentation there, Fionnuala, and just wants to ask, in the case of pregnant women with side effects or reactions to heparin, is it safe to use fondaparinux?
Yeah, it's a great question, and of course we have far fewer data surrounding the use of fondaparinux, but it can of course be considered again within the confines of a very highly experienced team. So this is also addressed in the European guidelines, if you like to refer to them as well. It's a tricky one, isn't it?
Yeah, it certainly is. And last question, Jerome Samakula, again, thanking you for a wonderful presentation. With regards to postpartum thrombosis, wants to know what the verdict is on DOACs, and certainly amongst breastfeeding mothers. Are they safe to use in breastfeeding?
So there are a number of registries collecting data at the moment, and what I might do is, I'm aware that there is one particular registry in particular that may have some additional data, but so if I'm permitted, I might send an update from that registry afterwards, Sylvia, because it's so crucial that we gather that the absence of data doesn't translate into no data, into firm recommendations. So we need to be careful, because we do need to prioritize studies that study in better detail the I suppose the effect of DOACs in terms of transmission into breast milk. So we just need to be careful that we are adequately counselling our patients based on most recent data.
And that, my lovely lady, is it. Thank you so very much again for your time and for a truly wonderful presentation. Very informative. Thank you very much.
And can I again, just apologise for having joined on my iPhone, and it's due to an unfortunate national IT issue that has affected Irish hospitals today. So thank you all for your patience with the mode of presentation. It's been an honour, and thank you very much.